So these are the disclosures. So there's specific anatomic challenges that you have to keep in mind, many of which you already saw referred to by other surgeons before me, specifically Dr. Pasanis. The overhanging ilium, the AIIS, where is that relative to the overhanging, relative to the acetabulum? The abundance of the muscles, the stiffness of the ligament, the mobility of the belly. Is it a soft jelly belly or is it a big basketball that just doesn't move out of the way? They create different challenges. And also keep in mind, these big, thick guys, it's not just muscular, they're also significantly retroverted on the femur side. So that means for a person that's off table, I start that case by telling my assistant, I'm really sorry. You're going to have to work a little bit harder during this case. And saying, okay, a little bit more, and then letting him relax and going back and take a little bit more and then relax a little bit, because unlike a table, that person has muscles that have to rest. You have to know when not to go. And when the skin is like this, it's just not going to heal well. So you have to be honest about that with the patient and with yourself. Set up in terms of the jelly belly, you've all had the experience of keeping the belly to the side just to get the necessary axis, because that belly is going to push you into excessive anteversion if you're not careful. Dr. Masanis referred to this. Make an incision so that the edges of the skin don't get excessively stretched. Dr. Ranawat used to always say, a size 11 dress gets a size 11 incision. Mobilize the tensor. The tensor has some adhesions underneath. If you mobilize it, that tensor will move, so when you put the retractor down on it, rather than just rip, it'll move away.